Now we will move into the last presentation, methodology adopted to provide mobile medical services, MMS, in an earthquake-affected, unreachable, underdeveloped region in Nepal. HHLK Fernando and DMDJ Dissanayake, presented by Lieutenant Colonel Dr. HHLK Fernando, Senior Lecturer, Department of Anatomy, Faculty of Medicine, Sir John Kothalaula Defense University.
Sir, thank you for your kind introduction. Let me share a few experiences which we had during the rescue mission in Nepal during devastating earthquake, explaining the methodology adapted to provide mobile medical services in an earthquake-affected, unreachable, underdeveloped region in Nepal. So, entering into the topic, explaining earthquakes, defined as a shaking of earth caused by wave moving on and below the earth's surface. Average 21 earthquakes occur annually, and unfortunately most of them happen in Asia. And low and middle income countries in Asia normally had more fatal earthquakes. Then the risk factors for fertility during earthquakes or after earthquakes, increased population, unplanned urbanization, and poor housing conditions. Then need of medical services after earthquake also behave in a different manner. After a normal, the devastating or a natural disaster, initial 3-4 days they need medical backup, so medical services. But when it's come to a earthquake, sustained increased demand to medical services last for 8 to 10 days. That is the difference between other natural disaster and earthquake. And provision of medical facilities during this critical time, during initial 10 days, determine the successfulness of disaster management. Then, as you all know, few factors about the earthquake hits the Nepal. Happened on 25th April 2015, magnitude was 7.9. Recorded 8,500 fatalities with more than 17,000 injuries. The devastating damage were much more than expected because of the geographical arrangement, traditional housing design, and the poor socio-economic status of the country. So this traditional housing design played a major role in giving more damages than expected. So we noticed, the very peculiar traditional design, housing design in Nepal region. So almost, unfortunately 95% of, the traditional houses are with this design. So houses are made from clay and mud and stones and wood. Nothing, no cement at all. The stones that they have used are in different shapes, different sizes, with very smooth surfaces. With this very unstable structure, they were building almost three-story houses. So first floor for animals, then the second floor for living of the people, and third, the small attic somewhere there for storing their foods. Then all the floors were done by wood, stone, and mud again. So these houses are very unstable, and strength is very poor. So this was the main reason for having such a devastating outcome after the earthquake. So you can see the difference between, the outcome. So this building made using cement, concrete, well structured. So this is, I mean, their traditional house is 2-story, mud, stone and wood, totally damaged. So that is, I mean, the one reason for giving such a devastating, unexpected outcome after the earthquake. So, however, after, I mean, calling for help, Sri Lankan government deployed emergency management team to Nepal within 26 hours. The team consisted of military doctors, army officers, army engineers and soldiers. The Sri Lankan team were assigned to manage the emergency situation in Dolagat region in Howrah district. So Dolagat, so this is the region the army team were deployed. So Dolagat region is a very underdeveloped mountain terrain. About 12,000 population were clustered in 30 to 40 small villages. So distance between these cluster villages varied from 2 kilometers to 10 kilometers. And the nearest cluster village is from about 15 kilometers away from the main road. Then the condition of the connecting road between these cluster villages were very poor due to destruction and obstructions occurred by the earthquake. And the other important thing, majority of the population of this region were illiterate, and nearly 25% of the population lived under extreme poverty. So then a little bit about the health system in Nepal. No free health care services for the people. Quality and accessibility is very poor, far below than the international standards. So in villages, what they are having something called sub-health post that is managed by a trained paramedics, no qualified doctor. So these centers are capable of handling wound dressing and giving only some painkillers. Then nearest health care station with qualified doctor is about 20 to 30 kilometers away from these villages. And if they want to reach a district hospital similar to our we'll say peripheral unit, they have to travel more than 50 kilometers. And unfortunately, almost all sub-health posts were damaged or completely destroyed due to the earthquake. So after visiting Nepal, we met some groups from Red Cross. They were established, I mean, the health camp near the road and struggling to reach peripheral people in the periphery. They didn't have any method developed. So what we did, we analyzed the situation and find three major problems. First one, accessibility, as I told you, the road network between these villages were totally destroyed and obstructed. So this is the condition of road. Even a 4-wheel drive off-road vehicle cannot reach the periphery. Then the second problem, inability to ensure further follow-up. Okay, we can provide primary care, but after that, who is going to do the secondary care or at least wound dressing? Because all healthcare centers were destroyed and any paramedics, even most of them also not there. Then the third problem, extremely low literacy and poor English knowledge made communication is difficult task with these poor people. So these were the three major problems that we identified, and we adapted or we adapted some measures to overcome these problems. So anyway, as usual, we made to establish two major health camps near the road. We selected two places to cater for people who can walk. These centers were kept functioning around the clock. Then the second most difficult task was accessing peripheral people. So what we did, we made a small mobile medical teams consist of one medical officer, two nurses, one pharmacist, two soldiers, two translators, and one Nepal army officers. we actually we utilize these soldiers to carry our stuff. So we have to bring all our personal belongings, then the drugs, equipments, everything with the team. Then we use two translators, one translator to be with the doctor while treating, and one translator to be with the pharmacist to give drugs. Otherwise, I mean, we had long queues. To reduce that, we used two translators. Then we accompany Nepal army or police personnel to get our security. So that's how we visited, I mean, the rural places by foot, no vehicles. Then that's how we treated. I mean, this actually picture I took on 4th day. Fairly big laceration without treatment. So this is, I mean, the appearance of a health camp that we did without any facility. So then anyway, using that model, we were able to reach periphery. But then the problem, how to give instructions about the drug dosage, because they were very illiterate. So what we used, I mean, we given instructions in sign languages. So on the envelope, we draw circles representing either tablets or capsules. So the first, 1 tablet or capsule 3 times per day. Then the second one, half a capsule at morning, 1 tablet in noon, and 2 tablets in nocturne. So that's the language that we use. So anyway, the final problem that we had, how to give, I mean, the secondary care. We can suture, but who is going to dressing and do dressing and cleaning? So what we did during our health camp, one nurse was assigned to train the capable person from the village. So we selected the person, young, almost, I mean, the most of the times young man, and we treated him basic wound care and give them a stuff with some equipments. And he is the person, he was the person who looked after the secondary wound dressing and so on. So after treating, I mean, the reaching, after 3-4 days, we revisit all the places where we had camps, and we saw significant results, and the trained persons were performing well. So anyway, conclusions and recommendations. Small mobile medical team is effective in provision of primary care for difficult to access communities in disaster situations. This mechanism is recommended to use in future humanitarian missions. Thank you.
Thank you very much. He has just described a devastating incident with his first-hand experience, and the paper is open for discussion. You have enough time.
Can I ask you the first question? Here. This must be the methodology you used to get people in the difficult terrain in the done by the army, no? Yes, that's the methodology used. Now, there must be other people you met from the other nations actually who came to do the help. Did they also follow the same sort of a methodology in the difficult terrain?
No, unfortunately, sir, we were the only team with such a preparation. Army personnel, medical doctors with army background, physically fit, and trained nurses to deliver such a service. So what they did actually, they joined with us and came during a later part of the stay. Especially Thailand Red Cross team gave us, I mean, the drugs, equipments, and they came with us.
Thank you.
So I have a small, now it's a real, extraordinary experience. I hope so. Supposing there is an earthquake in this country, which is a possibility, and what is the information, you have gathered some first-hand information and experience. If you are asked to train our people or teach our people, and what are you going to do really, based on what you have observed there?
Actually, after coming here, we designed a different model of delivering medical services in such a difficult state. So what we have to do, we have to establish a center with qualified surgeon, general surgeon, and basic instrument with nurses in a proper place. Where then we should have, a group of medical qualified personnel, doctors with some sort of physical fitness to reach periphery with nurses. Then we have to collect information, then we have to transport people who need further surgical care to the places that we are going to establish. So that is the model that we have to adapt. Because no point of sending a surgeon or a qualified doctor to the periphery, because they can't do anything. So such a model we have to implement it in the to get the maximum outcome. And we are now designing, low-cost four-wheel drive vehicle to reach these areas, and designing motorbikes which can be used to transport people.
Thank you very much. There's time for one more question.
Brought to the central centers where they could be given treatment?
Acute problems, so-called in surgical acute problems, were not there, because anyhow they have transported these people to district hospitals. But we couldn't get information about the outcome of these people. But there were surgical cases, chronic, not actually chronic,
subacute,
which were not attended at the correct time. We noticed two peculiar things about this population. One is their immunity. Even after fourth day, people with surgical wounds with minimum infection. We don't know the reason. The environment is so polluted. Polluted means not clean. Then their post-traumatic psychosis is very minimal. They handle that situation in such a way. We don't know the reason. We can't explain these two behaviors of these people.
Now you also mentioned that you set up a base camp where you had patients walking in. Did you see a different population of patients and injury patterns in those centers, or were they the same as what you noticed with the mobile teams?
No, we established these two centers after 24 hours, around 36 hours. So pattern we observed, most of medical cases came to these established medical camps. Surgical cases didn't come.
Any further questions to clear your doubts? So in the absence, we would like to thank you for your adventurous participation as well as